No, I totally expected that to happen.
Everybody.
2 weeks.
What's that?
You showed that video of the guy stuck in the elevator for 40 hours and had diarrhea.
Turn the phone off?
It's all done in that.
Did you turn the fan off? This
We turned it
this
low.
is low. Oh my god. Why?
You are into it.
Is our lesson to be aware of our surroundings?
Wait.
So you will have patients that will present like that, and there will be that moment where you're just like, they're just like, I gotta go, and you're like, yeah, whatever, and then all of a sudden they're like, oh, I don't gotta go anymore, and you're like, no.
Somebody put something down.
You didn't do that. I'll have to wait. Derek and I have an epic call that we both had together, where we both were working together, but it's much better when both of us are together telling the story, because we both have two different sides of the story on how exactly it went. So the next time you guys see us together, remind us about our poop call. So, all right. So, how's your guys' weekend? Awesome.
So great.
Yeah. Are you guys like totally getting this whole paramedic thing?
Oh yeah.
Does anybody feel like they're totally overwhelmed yet? Oh man, we're in like week 2, right? Like you guys have it? 3? Oh, we're just starting week 3, aren't we?
Yeah.
Do you guys have a plan? For those of you that are feeling like you're getting overwhelmed, do you have a plan to get yourself unoverwhelmed?
Don't stop.
Don't
Don't
Thank
stop.
you. Do not give up.
Hope there's no break.
Okay. So the big thing is so everyone is gonna kind of approach this at a different speed, right? There's gonna be different times when things are gonna start to click, and then you're gonna get it, and then you're gonna be like, oh, all this stuff makes sense, right? The big thing you gotta do is you gotta fight through this part where you feel like you're overwhelmed, you feel like you're not getting it, and spend extra time focusing on trying to understand these early concepts in order to make stuff successful at the end. What you don't want to do is you don't want to just like, I don't know what to do, I'm just gonna see what I can do, see if I can pass a test here or there. It's just gonna continue to snowball on you, and it's gonna head in the wrong direction, okay? So you have to maintain, you have to keep up, ask other people for help, ask the instructors for help, whatever you guys need, you gotta ask. Don't be afraid to ask. Everybody's going through the same thing. Some people will get it quicker than others, but you have to be willing to ask for help. because you don't want to get behind,
Bless you.
bless you. So, any questions? Is there anything I can do for you guys that will make you guys more successful? Nothing, you guys are just gonna be successful anyways, right? Yeah.
Do you have input on the meds that we get every week?
I do not, well, I did kind of this week, but I didn't actually respond, so I could have had input, but I didn't have input because I was busy at the time. But there are some, yes, I do have some ability in that.
Is there a reason that they're not given based on class?
Yes. We want you guys just to grab collective random meds that are attacking different body systems, so that you guys aren't just completely focusing on one group, because at one point, you guys are all, it's just gonna be all meds are gonna be open or scenario-based stuff. And so it's just kind of a, take this med, take this respiratory med, learn a little bit about it. Let's not overwhelm you with all the respiratory meds, because that's when you can start to mix the meds together. And like, kind of with our, we were talking to adenosine and amiodarone and cortisone and stuff. If you get all those at the same time, you start to mix those up. Whereas if you have groups of meds that are separate, it makes it easier to keep those separate as you're learning them. Does that make sense?
For the dosages, I've been using the Lane County protocols.
Okay?
I mean, a lot of them aren't on Lane County. Is there like any other, because I've been kind of bouncing around other websites to find like
Yeah,
dosages.
so the Lake County protocols will help you get a generalized dose, right? So, we were talking, 2 classes ago, we were talking about the whole CPAP with asthma versus non-asthma. So nationally, asthma is not a contraindication for CPAP, but Lake County protocols say it is. So we are gonna teach you guys the national standard stuff. So those Lake County protocols give you a general baseline kind of to start, kind of a reference point. And then it's kind of your guys' job to look at kind of more of a global perspective on what the dosage range is and see where those ranges are. And then when it comes down to testing and stuff, those ranges should be in your testing portion of it versus the absolute, so.
That's what I was just wondering, because everyone kind of seems to get a little slightly different. Hopefully it's about.
Yeah, so that's the thing. So majority of them should be ranges or ballparks that are fairly close in range things. So if you guys find something that's completely way different, bring that to our attention and then we'll get you guys the answer to go with on that.
Okay.
Make sense?
Yeah, thank you.
Do you have an office hour?
Office hour, yes. It's whatever I'm here. I do not actually have office hour, but I do hang out when I lecture in the morning. I am here until the 2:30. I don't go anywhere. I sit right here and I eat my lunch. So feel free to come up, talk to me during any of that time. I'm open. Yeah, so I'll be here. So I don't technically have an office hour, but I am here the whole time in between the lectures and labs. Anything else? Cool. All right. So we're gonna do some airway stuff. We're gonna talk airway today. So the airway management. So we have airway management. So that involves everything from your respiratory to your respiratory drive, your trachea, airway management, gag reflex. It involves all those things. But we're gonna start off. Some of this is a little bit of a review, a little bit of anatomy review, because the anatomy review is very important to us as paramedics, because we've got to know what we're doing, location-wise in the body, what tools we're using, and be able to recognize those things. Okay. So we're looking for optimal ventilation. We want to get the oxygen and CO2 exchange, right? That's our whole goal. We want successful oxygen and CO2 exchange, and we want to get that with as little work as possible. Some of the main things that are neglected, right there. Good face-to-mask seal, right? You can bag somebody almost better than you can use advanced airways, right? Does everybody know the right technique to use? Does anybody, how many people in here have legitimately bagged somebody with a BVM? Good, about half of you. So when you guys hit the OR, right? Ask those anesthesiologists to allow you to bag, okay? Because that's where you're gonna have the most control of the patient in a nice controlled setting. They're not gonna have a lot of vomit, they're not gonna have a lot of beer and pizza oozing out around the bags and the masks and stuff. But that's where most people struggle, okay? Like, people are so scared of touching patients and getting kind of rough with patients, like the head tilt chin lift. I watch people come up and they're like, okay, we're gonna do a head tilt chin lift, and they're all very gentle, modified jaw thrust. It's like, you gotta grab on, move that head, get that airway open, okay, and be aggressive with your patient. When it comes to the mask seal, you actually have to push to maintain that seal. If you're legitimately doing it right, you're gonna see basically the skin pushing out around the mask on the outside, making sure that you're getting a good seal. All right? Head tilt, chin lift. We use modified jaw thrust for what kinds of patients?
Spinal compromise.
Spinal concussion.
How many people have done modified jaw thrust on each other? How many people enjoyed it?
It's miserable.
Right? It's not very ideal. So that's one thing that we'll do tonight in the next two labs is we're actually going to do some modified jaw thrusts on each other just so you guys can see. Like legitimately, you really can't pull off a successful one with somebody that is conscious because they resist it, because it's uncomfortable, right? And so, once you do these two things, right? You got good face mask seal, you got good open airway, you have to continue to reassess. Do you get tired bagging?
Yes.
Does the patient stay completely still the entire time you're bagging with people moving and jostling them and stuff? No. So you have to continue to reassess to make sure that you're getting good face mask seal. A little anatomy review. Boom. Okay. All this is important to us. Why?
That's where the air goes.
Good. That's where it starts, right? This is where the air starts. It starts here, and we need it down here somewhere, right?
Right.
So as paramedics, why is this important? What do you guys feel are the most important things here that we need to be concerned about?
The tongue,
Oh, the tongue. Why?
because it likes to fall back in the back of the airway.
Okay, how do we manage that?
OPA and proper technique with the laryngoscope.
Good?
Or whatever.
Good? OPA, so as we walk through these, we're gonna start with basic skills, and then we'll move on to the advanced skills, okay? So, you always start off with BLS skills first, right?
Yeah.
Simple agile.
Because you don't just show up with somebody that's not breathing, grab the laryngoscope and go right at it, right?
Yeah.
I mean,
We were just talking about it, that's why it stuck in my head.
right? And so, yeah, so you always start with your BLS skills, right? So your OPAs, your MPAs, right? So then, yes, you can use your laryngoscope handle or your laryngoscope blade to get the tongue out of the way. What else is important here?
Epiglottis.
Epiglottis. So you got your epiglottis here, you got your epiglottis here. Why is that important to us as paramedics?
It's a landmark.
It's a landmark and it covers the trachea. Two huge things that we're concerned about, right? We're concerned about the trachea. Why are we concerned about the trachea?
Because we want access to
We
it.
don't want things going
That's
down.
where we want things to go,
Yeah.
like non-foreign bodies,
Yeah.
right? That's where we want our air, that's where we want our tube to go.
Yeah.
We do not want our tube to go back here, right?
Correct. Not an ET tube.
Not an ET tube. Good way to clarify. I like that. Okay? So we do not want our ET tube back here, right? But you notice how small it is back here and how big it is here? What do you think the chances are that it's going to end up in this esophagus back here?
A
High.
lot.
Yeah, right? It ends up back there a lot. Like, I feel like the odds should be in favor of us putting it in the trachea, but they're not. Okay? Why do you think that is?
Because we eat food more, well, not more than we breathe. but
We're
we eat
designed
food
to
a lot.
protect our airway.
We're designed to protect our airway. You notice it's a straight shot to the back of the throat and down, right? This one you have a little extra manipulation that you gotta do in order to make it down in here. Right? So we have all kinds of cool devices that we're gonna use. We have the epiglottis here that's there to protect the trachea. So once again, boom, something's working against us. So we gotta get that epiglottis out of the way. Alright? How about down here? Why is that important to us? What is this? What is this area?
Cricoid cut.
The larynx.
Adam's
Larynx, right? So that's what causes us to talk, right? So there's a lot of cool stuff here. This is some of the most important paramedic stuff. We can skip straight past all that BLS stuff because we've already transitioned. Boom, we're down here now, right? So once we make it down here, obviously if you got like a airway obstruction, then you're still in your BLS skills. But anything else, we've moved on to paramedic skills, right? We've moved on down here. So what kind of cool stuff do we have that's involved down here?
Vocal
Vocal
cords.
Vocal cords.
Vocal cords. Important to us, yes or no?
Yes.
Yes.
Okay. Where are the vocal cords located?
In the glottis.
right behind the
Below
thyroid.
the epiglottis.
Right behind the thyroid gland. In front
Okay.
of it.
So basically, right in here is your location. Actually, it's right at the thyroid here. And so if you can feel, like, right, grab your Adam's apple here, the top prominent portion, okay? The most anterior, all right, no, superior. Superior, most superior portion of your cartilage there is your thyroid cartilage, okay? That's the most important landmark for you to find. So now take your finger, run your finger down. You'll find a little groove there. Okay, everybody find that groove?
Yeah.
Okay, you can push on that groove a little bit. That location right there is below the cords, right? This portion here is your cricothyroid membrane. Just below it, keep moving down now. Now that is your cricoid cartilage. So you got cartilage on the top, cartilage on the bottom. Boom, we're gonna go back to that cricothyroid membrane. Okay, so our cricothyroid membrane, let's see if we got a good picture of it here. Right in here. Here we go. So here's your cricoid. You got a small little area to aim for there, right? So what do we do here?
Slice and dice. No.
Yeah, we slice and dice. We slice and dice. We can use a needle, right? So this is where we crike people, okay? So we have two different ways of criking people. We needle crike them, or basically we stick like an 18 gauge, if they're kids, 14 gauge if they're adults, into their needle, or into their throat. And then, how many people have like little coffee stirring straws? You know? Imagine trying to breathe through one of those things. So that's what you're doing, breathing through a IV catheter. Successful, ideal?
No.
No. So what do we do?
Make it bigger.
Bigger,
What do we do? What do we do as paramedics?
go big or go home.
Yes. Right.
Surgical track.
So we're gonna do surgical cracks. We can perform a surgical crack. We grab a scalpel, we grab a big old giant hook, we grab an ET tube, we slice open their neck, and we stick the ET tube in their throat. You guys totally ready to do that?
Yeah.
How many people would be nervous doing that?
Yeah.
Yes. I love it.
So
Love it. So when it comes to doing a crike, this is a no messing around decision making thing. Any one of these? Might as well take the whole thing. So when you make that determination that you're gonna slice open somebody's neck, at what point in your stress level have you reached?
It depends on how many you got under your belt.
I think
So-
you'd be nervous anytime.
I'm just gonna say I've been doing this for like 19 years now. 0. I've been part of one. It was really, really bad, really, really ugly, and it went really, really poorly. But what do you think was tried before we cranked somebody?
ET.
Everything else?
Everything under the sun. Okay? So a lot of times when it comes down to cranking, you are out of all of your tools. You've run out of everything. And so you were to that point where you're just like, all right, here's the Hail Mary, here we go. We're gonna try this. And you get to that point where it's just like, okay, we are now cutting somebody's neck wide open. Yeah.
How long did it take you guys to make that decision?
Less than 5 minutes total. Because it takes, and we'll talk about this. So it takes a little while for you to run through all of your skills. Go through your OPA, go through your BPM, go through, okay, there's something in there, let's suction, can we get the ET tube, can we not get the ET tube? You gotta prep your ET tube, you gotta get all that ready, can we do this, can we be successful with a king? You run through all those things, and while you're doing each one of those skills, it takes a minute and a half. Like when you got a good crew and a good team doing it. I mean, if this is your first day doing it, it's like you're gonna come up on that 10-minute mark where you're just like, okay, I filled up my syringe, check my bulb, okay, we're good there. Let's pull that syringe out. Okay, what's my next step? Right. So the more experience you have, the better at your skills you get quicker at making those multi determinations. Like, okay, yep, this is gonna work, this isn't working, and you just. So it's about 5 minutes in, and we're like, okay, this is not going to work. There's nasty, nasty trauma to the neck and face area. It's kind of like the lower jaw, and we're like, there's nothing being successful here. But do you think that these structures kind of have to be in place in order to be able to pull that off? So if you have significant trauma, do you think that it lowers your chances of being successful?
Yeah.
That's exactly what happened. It was a shit show. As soon as the syringe went in, it was blood all over the place. You couldn't find a landmark. everything was all destroyed in there, and so it was really, really messy. So let's see here. So what do we got over here?
Vocal cords.
Is this the view that you like to see?
Yes.
This is like the pearly gates of, like we are happy to see this. Do you think we're gonna see vocal cords every time?
No.
No. So what do you think you're gonna see when you go in to intubate somebody?
A hole.
So you got these vocal cords.
Maybe.
How do vocal cords work?
They vibrate and get smaller or larger.
Okay, so do they open or do they close?
Yeah.
Yeah, they open and close, right? So as you're talking and making noises and stuff, it's the air going past the vocal cords that's making the noise and stuff. So you got these vocal cords that are open and closing. So if they're not breathing, what do you think is going to happen?
That's close.
They're not moving.
They're gonna relax, okay? If they're not breathing, all right? So as soon as they stop breathing, because if they're, think about it, if they're not breathing, your vocal cords are closed, what's gonna happen? Are we gonna be able to pass the tube?
No.
No. So when they're not breathing, vocal cords actually open up, okay? So as people actually are breathing, so say you get to that point where you're making some determination, where you're not RSIing, they're at this agonal crash airway kind of thing, they're still breathing a little bit, a couple times a minute. There may be times when you get in there with your laryngoscope and you go to pass the tube and you're like, oh, and the vocal cords are closed. What do?
Wait a second.
Wait.
You wait a second and you wait for them to take that breath, okay? So when they take that breath, they open up the cords, you can pass it, and then what's gonna happen when they try and breathe again?
It's gonna close down again.
It's gonna close, but what's there?
Tube,
The
hopefully.
tube's there now, right? So what's gonna happen, do you think, as they try and breathe then? Are they gonna be irritated a little bit? Probably gonna get a little bit of gag reflex, kind of buck the tube a little bit. So this is where post-sedation medications, depending on how far they're down, you may have to give them some post-sedation meds to prevent them if they're still breathing. Make sense? Alright. Let's see here. So this is the view that you will see as you're going in to intubate. Okay, so this is the upside down, flipped around view of the vocal cords. So with this, we take our laryngoscope blade, right? We have Max and we have Millers. Everybody know the difference?
Max or curved.
curved.
Are you guys sure Max are curved?
Yes.
Would you guys be willing to bet your career on it?
Yes.
Love it. What makes you remember that Max are curved?
Because we
Max
just
for
had
Mac
this
and
conversation.
There's a C in
We
Mac.
just had
There's a
a
C.
conversation.
Exactly. And the Miller is?
All I's and L's, straight
L's,
down.
right? So you got the straight L's and the C, right? It's amazing how like people get all like, it's this and that. It's like, this is like one of the simplest ways to look at it. It's like, Mac is a C, Millers are L's, okay? So are both blades used the same way?
No.
Kind of.
Ish, right?
Their end goal is the same.
So what would you guys use if you guys like showed up today and were like, hey, you guys are paramedics, I need you to intubate somebody in the OR right now. What are you gonna use, Mac or Miller?
No.
Preference.
How many people want the Mac? 1, 2, 3, 4, so 5. Oh, okay. Oh, we got 6. How many want the Miller? 1, 2, 3, 4. Okay, so that's 10. I love how we have non-committal. How many people are gonna go with the anesthesiologist hands on?
Whatever they.
Right? So you guys will start to create a favorite. You guys will like either the Max or the Millers. There's also been additional blades called Grand Views and all these cool new ones that are out there. But you guys will develop a favor for one of them, one or the other, right? The thing is in the OR, you're probably not going to get an option. So we're going to play with both of them in the next 2 labs, so you guys can see kind of how to use each one. But whatever the anesthesiologist hands you, that's what you're going to intubate with, right? So you got to know how to use each one of the blades because they are used a little bit different. And we'll talk about that here after a while. So this right here is your trachea, right? So your trachea is a C style, right? Cartilage in the front, soft tissue in the back, right? So that's how you can actually pass larger objects, or not pass larger objects. That's how, as you swallow in the esophagus, things can pass down. It's not a restricted area. So what do you think this does to us?
Strict airflow.
Okay? So, let's get a good view of it. So we got our trachea here, and we're going to have our esophagus right here. Okay? So, as you start to bag for somebody, what we're going to want to do is we're going to want to grab our cricothyroid or our thyroid cartilage, and we're gonna push straight down. Okay? You can push straight down. What that's gonna do is that's gonna flatten the trachea up against the esophagus, flattening out the esophagus. Why do we want to flatten the esophagus?
Nothing much fast.
Less chance of us getting in the esophagus?
Good.
There's less of like a bend, and it's more like straight.
So when you're bagging somebody, should you be pushing some sort of crike pressure?
It would help lessen
Yes,
the
yes.
chance of air
If
going
you have
in.
extra set of hands, right? Because every time you're bagging somebody, you have like 1,000 people willing to help you, right? Not usually, but if you have an extra set of hands, yes, you want somebody holding crike pressure. Because what this is going to do is when you're bagging somebody, the air is coming in here. We're gonna say where you have not gotten to the point of intubation yet. Okay, we're still BBMing with OPA. So boom, in comes the air. Got our awesome OPA placement. So we're getting our air delivered right about here. Okay? So as the air comes in, our esophagus and our trachea are both open, right? So what do you think the percentage of where the air goes?
50-50?
Yeah, we'll just say theoretically 50-50. I mean, I'm sure it's a little bit different because it is a little bit of a soft tissue versus open passage, right? So we're just gonna say, we'll say 70-30. Okay, so 70% goes down the trachea, 30% goes into the belly. What happens if we push on the trachea?
Less goes in the belly?
Let's go in the belly. Why do we not want air in the belly?
Because it's going to connect us.
What? How many people do we go on that have had pizza and beer? Almost all of them, right? It seems like everybody's last meal is pizza and beer. We always get to see it, okay? So what we want to do is we want to avoid at all cost air getting into the belly. So that's why, like, as you're giving your bag, as you're breathing, you don't want high force bags, right? You want nice, easy breaths because you don't want to, because the easiest passageway is straight down the back, right into the esophagus. So that's why you give nice, easy squeezes on your bag to help aid you in getting air into the trachea. Yeah.
Is there any? I guess I've heard this in the past that once you you put the pressure down, that you don't want to leave.
Go.
Yeah.
Let go.
Yeah, that's what I was gonna ask about.
Right. So basically, what you've done is you kind of trap that air down in there, right? Any of the air that's already gotten down in there by the time you push. So you think of it as a balloon. You put air in there. Now you pinch the balloon off, right? So if you release the balloon, what's going to happen?
Air's going to come out.
So what you want to try and do is you want to try and hold until you can do what?
Suction.
Get a definitive airway.
Get your definitive airway in place. You want the trachea protected, okay? So once you have your trachea protected, you have your suction ready, you can always drop an OG tube down in there and relieve the air, the gastric distension, okay? So it's not one of those things where it's like a rapid, like, and everything comes out, right? It usually takes a little bit of pressure, a little bit of time, and a little bit of chest compressions and stuff for that to end up coming right back up.
You
Yeah.
said OG tube? What's the difference between an OG and an NG?
Size difference and direction of where it goes. So if NG goes in your nose, OG you can just drop it down and it's a little bit bigger diameter, so you don't have to go quite, you don't have as much nasal damage on the way in. Just size and depth for it. Okay? All right, okay. Any questions on that? You guys feel totally confident with being able to stick a laryngoscope in somebody's mouth and recognize exactly where they are and what you're supposed to do? No.
Confident?
I didn't think so. Because I don't either. Wait. Okay, so once we make it down past the trachea, we got all the bronchioles and bronchus and everything like this. We know all about this stuff because we're good at anatomy, right?
Correct.
Yes? You guys good on this? You guys
Yes.
know everything?
Yeah.
It makes it all the way down to the villi. Villi are important to us? Yes?
Yes.
Very important to us. Are there medical conditions that affect the villi that are important to us?
Yes.
As
As advanced airway management people, is there stuff down here in the villi that we are concerned with? Like what?
Like mucus.
Mucus.
Mucus, COPD, pulmonary edema, yes. So all of those things are down in here that get down in here and affect that stuff, right?
drugs affect that.
So this is where we have to know how to manage that in order to, it's a collective management cycle that we go through. It's like just because we have our airway taken care of now, because somebody was drowning because of CHF, we decided to RSI him and intubate him. There's a whole lot of other stuff going on now that we have to help out and work through the system, right? So it's not just a boom, you work through your ABCs, right? Airway, breathing, circulation, you get your whole picture, make the determination where you're gonna go, what you're gonna do, and then you start your treatment plan, okay? Pediatric differences, okay? So one of the biggest ones is the tongue, right? Has anybody ever bagged a kid? Oh, you guys are lucky. So these are the most stressful calls that you're gonna go on, because everybody else is stressed out. But you guys are gonna be so awesome at your skills by the time you get out of this paramedic class, that you guys will be the calming factor for all the old veteran paramedics out there that are just like, oh, it's a kid, ah! Right? Because you guys are super dialed on all your stuff. That's what I'm gonna tell you guys, right? What do we have to fall back on?
Our training.
Our training, and what did I show you guys the other day? This
Our,
big giant kid that takes a
Broslo.
lot of the decisions. Broslo kid.
Broslo.
Broslo kit, Broslo tape. Takes a lot of the stress away from it, okay? A lot of the old, the Broslo kits are a newer invention within the last 10 years. Some of the older paramedics didn't have as a tool, and so they refer back to their training. Their training was they had to memorize all those things, and now they feel, oh, I don't remember any of those because I haven't read the pediatric code in a long time. Okay? So, pediatrics are stressful. Tongue takes up a ton of space. How are we going to manage that tongue?
With simple adjuncts.
Okay,
First.
and
Great positioning.
positioning. Yes, positioning. Epiglottis. So we think it's big in kids in relation, or in adults in relation to the mouth, because there will be some big floppy epiglottises that are out there, and you're just gonna be like, I can't get this thing out of the way. What do I do? How do I manage this? Kids, it basically like covers their trachea and their esophagus all at the same time. I mean, their glottis is just so large in comparison to the adults. It becomes very, very difficult to manage, and so that's why they've actually they're going away from intubating kids a lot of the time now, because there's been such a large unsuccess rate in those. And so we'll go over that as we do our skills portion of it on how to manage that glottis in kids. The larynx of the kid. How do you think that is, why do you think that's important to us as paramedics?
Because that's our area.
That's paramedic area. We're getting good. We're recognizing, okay? So it's our area. And what do we need to know about that area? Are we gonna crank a kid?
Hopefully not.
Kid has a really bad day, right? Do you think you're more likely to crank a kid or an adult?
Kid.
Why do you think a kid?
Allergic reactions, blockages.
So most of the time, adults don't shove a whole bunch of things in their mouth and block their airway. And so kids frequently will swallow something, put pressure on, make it to the point where they are actually choking, and you may have to crank a kid. Bad day. So knowing that the trachea is super small, right? Trachea is like, if you look at kid's finger, if you take like a pen, so that's about the size of a trachea in a pediatric, right? It is the smallest portion of the airway for the child, is the area of the vocal cords. So this is why when you guys go to intubate stuff, the ET tubes are non-cupped in pediatrics, because the cartilage of the trachea will secure the tube on its own, will help to secure the tube on its own. You will have the death grip on the tube from the time it passes the cords until you get to the hospital, right? Because moving this far in a pediatric, you know, like as you're moving the kid and stuff, moving this far is going to potential of pulling the ET tube out of the trachea, right? So a good way of managing a pediatric is once you've intubated that kid, put one hand behind their neck, so you're stabilizing their neck. Your other hand's right up here on the ET tube, anchoring to the side of the face, so you know the neck moves, the head moves, the neck moves, the head moves, the ET tube doesn't move at all. Okay, so you're holding that throughout the transport, yeah.
Could you use like a tube tamer, like?
You could use a tube tamer, but if you think about it, so the tube tamer secures it right here, right?
Yeah.
So if you go like this and extend the neck on a kid, is it gonna move down here?
Yeah.
You have the potential. So yes, they say you can use tube tamers and stuff, but I have legitimately seen small movements dislodge a tube. Right? You guys have some pretty awesome videos to watch, some of those end-title videos. End-title is amazing for ET tube placement. You will instantly know whether or not you have dislodged the tube. So I can't stress enough how important it is to use end tidal whenever you intubate somebody, especially when you start moving them. All right? Belly breathers. Kids breathe with their bellies, right? What happens if they start breathing with their chest muscles and their neck muscles and all those extra accessory muscles?
Very in trouble.
They are in trouble, right? You are behind, correct? Now you have to get much better at your skills instantly, right?
Right.
No, because you guys were awesome with your skills already. And so you're like, oh, we got this. It was the parents' fault. They waited to call us. Yeah. No. Yes. You have to ratchet it up a little bit. Okay? So you have respiratory system, ventilation, inspiratory, expiratory, the Herring viewer. Yes, reflex. Brewer, reflex. So everybody takes a deep breath. Keep taking more. Take some more. Keep taking breaths in as much as you can. Let's go. Overinflate. Here we go. Pop your lung. No, you can't do it, right? This is the reflex that's designed to prevent you from being able to overinflate your lungs, right? Do unconscious people have that? If we have control of the BVM? No. So what do we become?
The popper.
We become the reflex, right? Or the popper. One or the other. Hopefully you guys are amazing at your skills and you guys can recognize compliance, how well it's going, you notice hyperinflation and things are getting bigger and you're like, maybe I don't need to put quite as much air in there, okay? All right, so you have multiple different exchange locations, external and internal. You have gas, you have the alveoli, the blood cells, bloodstream to tissue. All right, hemoglobin, transport mechanism of the red blood cells for gas. Important to us, yes or no?
Yes.
Why? As paramedics, because we are far advanced.
SpO2 monitoring.
All right, what's that tell us?
Tells us the saturation of the hemoglobin.
Tells us saturation of hemoglobin. Is that important to us?
Yes.
Is it accurate?
No.
No. Well, it doesn't.
Depends on
It doesn't.
Trick question.
It's
Depends on-
accurate, but it doesn't tell us
depends.
if the cells are using that oxygen.
And it doesn't tell you how much hemoglobin you have.
Yes, there we go. So you're getting 100% sats on somebody. Cool, they have one red blood cell in there, right?
100% of one.
1 for 1, 100%, boom. This person doesn't need oxygen at all. Nope, we're good. Yeah? So if they have one red blood cell and they're sat at 100%, do they need oxygen?
They may, depends on their.
Well, they don't have
Well, they
hemoglobin
can't, they
to carry that
can't, they
oxygen.
can't carry any more.
There's nothing else they can do. So
Oh,
what do we
yeah.
need to do as paramedics?
Diesel and get to the hospital and get red blood cells.
You didn't get red blood cells, huh? So not everybody here is good at driving an ambulance. There could be people that are life flight people, so I mean, they could be carrying blood, I mean, so the whole diesel therapy goes out the window as paramedics now, because not everybody's gonna end up. Some departments are gonna carry blood, some are carrying plasma now, and so there's all kinds of different things out there where that whole diesel therapy is awesome because that's what a lot of the old practice was, but now we're becoming like more of a mobile care stuff, critical care stuff. So the recognition of no red blood cells, what kind of conditions are those? How are you gonna recognize?
Hypovolemia.
Hypovolemia, yeah, that's the go-to number one, right? That's the easy one. So you got somebody with a blood pressure of 60/40, and they're bleeding out. How much fluid are you gonna give them? Okay? So, I mean, you're dumping, they're bleeding, you dump 3 liters into them. And they're still at 60/40.
Can we do anything
Stop
to plug the
bleeding.
hole?
Well, it's a nasty internal trauma
Yeah.
thing.
Open them up.
How do we deal with this diesel therapy?
If you have the option of getting them blood.
Right. So this is one of those cases of if you continue to dump fluid into them for somebody that's bleeding already and their red blood cells are sat at 100%, all that kind of stuff, they're losing all their red blood cells. What do you run the risk of?
Taking out all their red blood cells.
Taking all their red blood cells out, so
And
you're
replacing it
increasing the
with just
pressure to
fluid.
force. So now you're causing them to bleed more. They're losing more of their red blood cells, which takes all their oxygen transport away. Right? You're diluting what's in there. So before too long, you're going to have a 7-liter bag full of saline person that, as they start to bleed, you're going to be like, oh, I see CSF. It's coming out of their belly, but it's CSF because it's clear. And then it's like, oh, wait a second. And so the reason I bring that up is because I had a significant trauma like one of the last calls I had over in Florence, I dumped 5.5 liters into this guy. I could not keep his pressure up. I was just like, I don't know what I'm just like, I just couldn't do it. We are aside this guy. It was like a 2.5 hour extrication. And I was just like, yes, I got the guy to the hospital alive. I was excited. So the trauma surgeon sends me a little personal note saying, hey, just a little FYI, this guy was diluted down. His hemoglobin level was basically 0. I'm just like, ah. And so he's like, hey, give me a call. Do you normally get a hey, give me a call from a trauma surgeon?
That's great.
On your chart review? Never.
Yeah.
So how do you think that phone call went? Surgeon was super cool. He's like, dude, I totally understand what you were doing. I totally get it. He's like, but think about it this way. And then he explained exactly what I just did. He's like, you're diluting it out, you're eliminating it, you're increasing the bleeding. I was like, so do I let him die? He's like, no. He goes, but when you talk about that 100 level that you try and keep people at, that systolic of 100, when it comes to somebody that's actively bleeding out and you can't keep up, it's okay to drop that down a little bit to the 80s, to the 70s, because you're still technically perfusing the main organs, right? So you still have a radial pulse-ish, depending if you're at the 70s, 80s area, all right? And so he says, just start to become thinkers as you start, instead of just, I'm going off this number, I have to get this number, boom, in goes the fluid, I'm running wide open, I got like 4 IVs going, I'm like, I am doing this PHTLS thing. Like, it was awesome. Like, we had 4 14s in this guy, and I was just like, open them up, let's go. I mean, and we were flowing fluids. I was just like, and then I hit a pressure of 100, and I'm like, and we'll back it down a little bit. But we already had 4.5 to 5 liters in this guy. And so he just had it circled on my chart. He's like, and a big question mark next to it. And then I was just like, geez, this isn't good.
So what should you have done?
So not run as much in
Okay,
and titrate to a lower pressure.
okay.
So run it more up to a 70 systolic, 80 systolic versus I gotta get it to 100 and get it to there.
Just enough to.
Could you tell where he was leaking?
No, it was all in his belly. Couldn't find out he had ruptured, he had perforated part of his bowel, and it was all in his intestine region.
But you could tell that he was leaking in there.
Yes, he was getting very distended abdomen. We knew we were in the trachea. He was getting, we call it a hot abdomen, as in it's rigid. So it was filling up with blood, and it was just, it was bad. Yeah.
Is there any sort of synthetic or drug that you can give that can carry oxygen for them?
Synthetic, I do not have that answer for you. I couldn't tell you. We do not carry them.
Are you talking True Blood?
Huh?
Are you talking True Blood? I'm just asking if there is something that you can
Or is
carry.
this some sort of vampire thing, something or another? So yeah, I have no idea. Never heard of it. I have not heard of it. So
There's no sort of drug that can help with like carrying more oxygen in the bloodstream.
Let's Google it.
yep, you'd have to Google it. I couldn't tell you.
GTS. Google it.
So, decreased oxygen levels. Paramedics, you're gonna recognize this stuff. You're gonna know why this person has low O2 sats, right? You roll up. You're an EMT basic. You're like, oh, they got low O2 sats. Let's put them on oxygen. We're gonna fix it. Now you're paramedics. Now you're thinkers. You're like, oh, we got low O2 sats. Let's hold off on the oxygen. Let's figure out what the problem is first, right? You get the whole picture first, then you make the determination and start your treatment plan. So, decreased hemoglobin concentration, we talked about that, bleeding out. What's another one of a decrease? Say a medical patient, you show up and they're like, I can't catch my breath. I just can't, I don't know what's going on.
Sickle cell anemia?
Sats are 100%, but you know what, I'm just having a hard time breathing.
Carbon monoxide poisoning?
Nope, we're not gonna get there yet, but we'll constantly hemoglobin concentration portion.
Anemia?
Concentrations are low.
Any like sickle cell anemia or any of the other?
Anemia, right?
Anemia.
So you don't have the red blood cells in there. So what kind of questions would you ask somebody if you suspected anemia?
The history of anemia.
They don't know what anemia is. You say anemia, and they're like, what is that?
Have they been to
Is that
Africa?
contagious? I don't know. Have they been what?
Have you been to a malaria infested area recently?
No. But we're gonna ratchet that back to basic questions, right? Or
When was
sorry,
the
when I
last
say
time
basic,
they
not
ate or
EMT.
drank anything?
What's that?
When was the last time they ate or drank anything?
Breakfast?
Is this male or female patient?
Let's say it's a male.
They,
What'd you have?
Are they African
Oh,
American?
it was awesome. I had waffles and bacon and eggs and hash browns and a little bit of toast with some jelly on it. Had some orange juice, a little bit of fruit on the side.
I don't care anymore. Stop.
Oh, you want me to keep going? I mean, I can keep going. I mean, cereal and eggs
yeah.
Benedict. So you gotta watch out for questions like that, right? Because you're gonna get a whole bunch of answers and it's like, okay, I just killed 10 seconds of my life. I'm not getting back. But I need pertinent question answers, right? So, anemia, red blood cells, hemoglobin, you're losing them,
Have they had an infection
but they're
recently?
medical. Think medical related stuff.
But they don't.
Non-trauma, losing red blood cells.
Stool, what's their
UTI,
stool? They have
GI.
an internal bleed.
Stool, ins and outs, right? So you always want to ask, so you get the first half, you get the ins and outs, okay? So you want to know, how has your stool been, right? Has it been normal? What does normal mean? Oh, geez, you never want to ask normal.
Has it been dark and tarry? Has
Oh,
it been,
dark
see
and
blood?
tarry, the infamous dark and tarry. Have you had any blood in your stool? Have you had any bright red blood? We'll get called for GI bleeds all the time for people that get put on a specific med. Any ideas? No?
Iron.
Iron. Patients that are on iron have dark black stool. So they automatically think, boom, I'm bleeding out, this is it, this is the end, and we get the call, okay? So dark tarry stool, you have two different approaches there. You got the patients that are on iron, and you have the patients that are actively bleeding somewhere in their GI tract. So dark tarry stool, that's gonna tell us the potential for a GI. So now, so they're sat at 100%,